So welcome everyone. For those of you that I've not met, I'm Anna Patel, one of the pharmacists working in the digital medicines team at NHS England. I'm pleased to see so many of you have joined today's masterclass. And just for those of you that are new, the purpose of the masterclasses is for organisations to share their experiences and learnings of digital transformation to help support others. And the aim of this platform is to break down silo working, create a community, and enable other trusts to learn from each other. So just a bit of housekeeping today. We've got two presentations. One is on challenges and strategies implementing ePrescribing in a mental health setting, and another presentation is on critical success factors for implementing EPS in CAMHS. And there's also a question and answer box on your toolbar, and you'll be able to then ask any questions for our presenters in that box. And after the presentation, if we have time, I'll ask them directly. If we don't have time, then these will be answered after today's masterclass and shared on the NHS Futures platform. Certificates of attendance will be sent out after today's webinar to everyone that's on the call today, and you'll also get access to the recording of today's webinar. Finally, if there's a topic that you would like to present on, please do get in touch with Sarah from the Health Innovation Network. Her details will be put on the last slide before we close today, and we're always keen to have presenters on to share any digital innovation that's going on across the NHS. So without further ado, I'm going to start with our first presentation and just a bit about Yvette. So Yvette is the ePMA lead pharmacist at West London NHS Trust, specialising in digital health and electronic prescribing systems. She has been involved in ePMA implementations across acute mental health and outpatient settings, and she's currently completing the Digital Health Leadership Programme. Yvette is focused on advancing digital transformation across the healthcare sector with a particular interest in AI-driven solutions to improve medication safety and streamline workflows. Once again, please do put your questions in the question box, and I'm going to hand over to Yvette.
Thanks, Amna, for the introduction. So today I'll be sharing some of the key challenges we faced in implementing ePMA in a mental health trust and how we've developed strategies to overcome these obstacles. Next slide, please. So when implementing ePMA in a mental health setting, we face some unique challenges and obviously some that would overlap with acute. So a mental health setting presents complexities such as regulatory compliance with the Mental Health Act and the deprivation of liberties, liberty safeguards, which is the DOLS, and then covert administration is another one that comes up, and witnessing requirements for high-risk medication like antipsychotic depots add further complications as well. And we'll also discuss system and workflow challenges and how we've worked to improve training and engagement on those as well. Next slide, please. So one of the major challenges we face in mental health settings is that many patients lack capacity to provide informed consent, which complicates medication management. This is why it's critical to ensure that the Mental Health Act and deprivation of liberty safeguards are fully integrated into ePMA workflows, allowing us to manage consent and legal requirements more effectively. One way we had done this was documenting it as a freehand drug prescribed QDS to ensure that the nursing staff was aware of it at every drug round and having to refer back to paper every time just to double check. Another way after that was documenting it as a banner on the patient's profile to inform that this patient is under the Mental Health Act, and then the nursing staff would still have to refer back to the paper. And finally, now we have access to a Mental Health Act module that allows us to seamlessly integrate that information and also set expiration dates, which is really important to make sure everything we're doing is above board. Another key aspect is MDT collaboration. So effective treatment requires close coordination between pharmacists, psychiatrists, nursing teams. Real-time communication through ePMA system ensures that we can adapt treatment plans quickly, keeping patient care consistent. One really big issue we've had here is read-only access hasn't been built into the system, meaning that our dietitians, our physios, etc., were excluded. So we've since requested this feature to ensure that our colleagues have access to the patient's chart where appropriate, because it's really paramount that they have they have access to things like this. So for instance, with our physios, they can look at the drug chart and say, actually, this medication can cause falls, so I'll be on the lookout for things like that. So yeah, it's really paramount that everybody who needs access has access. On top of that, mental health patients often require complex and changing psychotropic regimens, and this includes covert medication administration and the witnessing of certain high-risk medications, which adds to the layers of complexity to the workflow. And we've handled this by adding an attribute to the patient's profile to indicate if the patient's on a covert admin. Also, within each drug note, we include the covert admin instructions as well. So how to crush it, if you're supposed to keep it out of the sunlight, things like that. And then finally, system downtime poses a significant risk in mental health settings due to the time-sensitive nature of medication administration. In the first few downtimes, we had noticed that not everyone was aware or had forgotten how to access the BCP. So what we've implemented now is a system where the wards are checking the BCP process periodically and documenting their checks, just mostly to keep memory active and to ensure that everything's working as it should be. Next slide, please. So another thing, building on what I mentioned earlier with the Mental Health Act assessment and DOLS, it's critical that we maintain accurate documentation to ensure legal compliance. So for patients detained under the Mental Health Act, regular updates on their section status are really essential. And again, this is why we needed view-only access, so our Mental Health Act office has access to it and make sure that we're staying on top of it, which is another added layer of security. So we're currently using patient attributes to document this information as well as expiration dates. And then in the upgrade we're implementing in the coming year, this will be done through the Mental Health module, which allows us to document the section status and approved medications as well as expiration dates seamlessly. And in cases where patients lack capacity, DOLS authorizes treatment as well. By integrating DOLS workflows directly into ePMA, we'll be streamlining legal oversight and consent processes, ensuring that medications are only administered once all the necessary approvals are in place. Next slide, please. So in mental health settings, covert administration, so giving medication without the patient's knowledge, comes with serious legal and ethical responsibilities, and it's something that we unfortunately frequently have to do. So the main challenge is ensuring that at every instance of covert administration, it's properly documented and justified within the ePMA system as well as the EPR. So initially we addressed this by adding a banner to this in the system to remind staff to refer to the paper-based documentation. And we found that it was working, but it wasn't the most effective way of doing it. So over time, we've refined this process by adding a banner to the patient's chart indicating that they are on covert administration, but also adding the details of a detailed drug note explaining how to crush or prepare the medication for covert administration. And this ensures that the process is clear for staff and is compliant with the legal requirements as well. And then for witnessing, especially with high-risk medication like antipsychotic depots and insulin, we face challenges ensuring that all staff, particularly locum or temporary staff, follow the witnessing protocols consistently. So locally, we request that with things like this, we get 2 signatures on them instead of just 1, just to ensure we minimize the errors. So our system didn't initially have a native support for witnessing these medications, so we worked on the back end to implement reminders and mandatory steps like this. So we've also preloaded instructions for post-depot monitoring, just to make sure that patients are being monitored afterwards. So things like patients being monitored for 3 hours post-dose, things like that. And again, this wasn't built into the system originally, but adding these instructions just really ensures that the staff don't miss critical monitoring steps after the depot administration. And our nursing staff have been really thankful for this. And to ensure ongoing compliance, we've adopted several practical steps as well. So first, ward pharmacist conducts regular reviews of covert and witness medication records to catch any documentation gaps. And then we've also provided staff training on the legal and procedural requirements for covert administration and witnessing and how it now looks now that it's fully digitized. Next slide, please. So the system outages and technical limitations obviously present significant challenges in mental health settings where medication regimens are time sensitive and complex. Delays in administration, especially with high-risk medication like psychotropics, can increase clinical risk, especially during an outage, which we just had one actually yesterday. So they're not infrequent. And one major issue we've encountered was related to special characters breaking the entire system. So if somebody logs in, prescribes something like glucose 40%, that percent sign, that special character, when entered into the patient's chart, it would block access to the patient's records. And then not just that, it would actually affect your ability to access other patients' records. And it became really, obviously it's a big issue. So users had to log out and then log back in and avoid that specific patient to access the patient's chart. We've flagged this with the supplier, and a fix is planned in the next system upgrade. But in the meantime, we've advised prescribers to avoid using special characters, which has helped prevent further disruptions. So small things like that can really make a huge impact. Another technical limitation arose with the system updates being scheduled during the weekends and off-peak times. It was supposed to be so that they're the least disruptive times for an upgrade. But while the intention was to minimize disruption, this often backfired. Fewer staff were available to enact the BCP if there was a system outage, and there has been, and the ePMA team wasn't on hand for support. We requested then after that updates be scheduled during the regular work hours, so Monday to Friday, 9 to 5, when more staff are available, which has significantly reduced disruptions and improved overall efficiency of the system. And then we've also found a critical issue where patients' allergies weren't transferring from the inpatient ePMA chart to TCAs and STLs. And upon investigation, we discovered that some allergies weren't SNOMED coded in the EPR system to begin with, which caused them not to appear on discharge scripts. And this posed a serious risk, obviously, for patient safety. So we've logged this with the supplier, and they've confirmed that this issue will be resolved in the upcoming version. And in the meantime, we've informed prescribers and ward pharmacists on how to identify allergies that aren't SNOMED coded, how to re-input them correctly, and to be vigilant for when reviewing discharge scripts. And then finally, regarding our business continuity plan, in early stages, services were hesitant to make the decision to switch to paper without checking with us, the ePMA team first, which obviously caused delays in treatment, particularly outside of our working hours. And we worked closely with the teams to build up their confidence in enacting that BCP independently. Now, whether it's a single patient issue or a system-wide outage, services are just so much more comfortable switching to paper immediately and informing us afterwards that this has been the case, rather than waiting for our approval in the first instance. And this shift has really improved response times and ensured smoother transitions during downtimes as well. And most importantly, it means that the patients aren't waiting for their medications. And then next slide, please. Another thing that has come up has been training, which is training. It's obviously a critical component in ensuring that successful implementation and ongoing use of ePMA in mental health settings. So given the diverse needs of our staff as well, we adopted a hybrid training model. So we offer both face-to-face training as well as virtual sessions. And this flexibility has really been particularly helpful for remote and locum staff who might not always be on site or might be on site just before their shift only. So ensuring that everyone can access the training they need has been really good. And then our training is tailored specifically to mental health, covering areas such as the Mental Health Act, deprivation of liberties, covert admin, witnessing process for high-risk medication. And these topics are really essential for staff to understand given the complexities of working in a mental health environment. And just making sure that they're really confident with the system has been really good. To maintain ongoing support, we've also implemented regular touch points and drop-in sessions. So we call them our virtual coffee sessions, and we hold them bi-monthly. And we've done this everywhere we have already gone live. So post-go live, everybody has access to these. And we also encourage staff to email our shared ePMA inbox to log queries and requests for updates. And these sessions have helped build staff confidence and has given them the chance to address real-time challenges as they encounter them as well. And we found this approach has been really effective in reinforcing learning and troubleshooting issues early. So we keep a log of all of the issues that have come up. And then if something has come up on several occasions, what we usually do is we incorporate it back into our learning. So one of the most important aspects of our training program has been that feedback loop that we've created. And we actively incorporate staff feedback into our training material, ensuring that the content stays relevant and aligns with the realities of the day-to-day work. And by listening to our staff and adapting our approach, we've been really able to continuously improve the training process and make it more practical and responsive to the challenges that the staff face. Next slide, please. And yeah, so that wraps my presentation up. So thank you for your time and your attention today. I hope, I hope it's been helpful, and I'm happy to take, I'm gonna have a look now at the questions.
Hi, Yvette. Yes, thank you. There's quite a few questions in the questions box, but first question is around what actual ePMA system are you using? Because quite a few people have asked that question.
Yeah, I think I should have clarified at the beginning, actually. We're on Civica. So they've been really good in terms of when we pick something up, they've been really responsive with us. So yeah, Civica's been really good, and there's quite a few of us as well that are using it. So we're really lucky in the sense that we have like a big network of Civica using trusts that we can access.
And there was another question about, I think someone was asking to see the sort of flags that you put, you were talking about having some flags that you put on the actual record itself. I know you haven't got any images now, but I guess if you're happy for people to get in touch if they want to see what that looks like or not on the system itself.
I can screen. Yeah. And then some stuff would be like the patients on insulin. That would be a really good one to just like let whoever is looking at their chart know. Yeah, and things like that. I can send screenshots of different ones that we've been using, or patients on valproate, or patients on lithium. And then in mental health, we also have something called HDAT. So it's high dose antipsychotic treatment. So if the patient's on 100% or above the BNF maximum dose, we also will put that on there just so we're on the lookout for symptoms and side effects and things like that.
And we had another question about how does the system manage future administrations? For example, the depot injection prescribed the week before the administration is given in an outpatient setting for the following week. Do you know how you'd manage that?
Sorry, which person asked this question?
It was from Derek Robertson, and it was around how does the system manage future administrations? For example, the depot injection prescribed the week before the administration is given in an outpatient setting.
Ours is
the following week.
Straightforward, to be honest, because on our end, it just you set a future date, and it's as simple as that. So I wonder if they're using a different system. And it looks differently on their end, but ours, it's just you set a future date and that's it. So even in situations where we were transcribing that day and the patient didn't have their depot until next week or something, you just set the start date for the next week and that was it.
Okay, and there was a question around for covert administration, which MHA documentation is used.
Which sorry?
It's from Ashok.
For covert. Oh, okay. So yeah, for covert administration, so we have the agreement that the legal agreement that we do, and it requires obviously the sign off of a patient's family, and it's only done once the MDT has decided that this is legally possible. So we have the paperwork, we have it on our electronic system, but then we also have the banner on the patient's chart. So that's one. Saying that the patient's on covert administration, and then within each drug we'll also explain how to crush it, and then also the expiration date, which is the most important part of when that agreement runs out, so that it has to be renewed on an MDT decision. So they are still technically supposed to be referring to the paper, but this is just as a way of making things a little bit faster, so you're not looking at 3 different spots to kind of administer the medication.
And then there was a question from Marvin, which was, do you have defined downtime period before the enactment of BCP?
I wish that we did. We usually don't get a heads up from Civica, to be honest. I wish we did, but no, we don't usually get a heads up. Sometimes they will say there is going to be an upgrade happening during this time, but there have been equally times where they haven't told us. So if we do get the heads up, we will forward it onto the rest of the staff using a trust-wide email. But yeah, so if we do get an update, we share it.
Yes, I think there's a follow on there about, do your wards regularly check the BCP and enact it in test situations? Is that a regular?
Yeah. So that's something that we've initially we were saying it was supposed to be once a year or once every 6 months, but we've made it so it's once a month now, just so that they're remembering, because a lot of the time when they don't have to access it very frequently, I totally understand. I wouldn't remember how to do it either. So it's been really helpful having that log of oh, okay, person X tried it. It's everything's good, and they printed a specific patient, everything's functioning. So yeah, it's been really helpful to do it a little bit more frequently.
And there was a question from Stephen about how did you build the decision support tools?
That is not on our end, actually. This is something that Civic has done themselves, so it wasn't on our end.
Okay. And then there was a question from TF Chan, which was, can you prescribe short-term leave on the system that you have in place? So for patients going on short-term leave, are you able to do that on the system?
Yeah, it's really good as well, because on Civica, I think JAC as well, you can set it so it gives you, on the short-term leave prescription, it gives you specific doses needed for that specific amount of time. So if the patient's only going during lunch, they will only get prescribed their lunchtime medication. So it's really good. And we've gotten a quick reference guide out that helps you just do it really quickly. It's maybe 3 clicks. So it's really good on Civica, to be honest.
And a final question, I'm not sure if you can see it in the chat box from Richard Mellor, it's quite a long one, is we are currently trying to find an effective way to document reoffering medication after initial refusal. Some patients may have a medication prescribed in the morning that is reoffered for the rest of the day. Our system has the ability to add a note to the administration saying it was attempted, so it's good documentation, but it's time consuming and being added for every medication individually. Because of this, it's not robustly done. Sometimes refusal is used, but then this removes the medication from the nurse's work list and reoffering is missed. Did you have this issue and a solution for this?
Oh, that's a really good question. I think that's, yeah, I think it happens a lot in mental health settings as well. So what we've noticed our staff has been doing, and we think it's a really good process, to be honest, is if the refusal has happened, they will mark it as refused. But our system also allows us to, so I think it depends on the nurse's knowledge of the patient as well, because some patients, we know that like if they refuse now, that it's a no, so they just mark it as refused. But if they're sleeping and they'll said, oh, I'll get up in like 20 minutes or something like that, they'll just wait until the patient is awake and then they'll administer it. But the official way you're supposed to do it is mark it as refused initially, and then on our system, at least on Civica, what you can do is go in again and then mark it as patient administered and then explain why it was refused initially but then administered later, and the system's quite flexible in that end. So there's no real prompt for it to be given again if the patient's refused initially. So it depends on the patient essentially coming to you or the nurse checking again. So in terms of like a system to remind, it's not there, but it does allow you at least to document the fact that on the first instance the patient has refused, and then the second instance they actually did take it, and the time it was taken and why it was taken late. So the documentation side of things is really good, and it doesn't allow you to go forward with the administration unless you've documented. So the documentation is kind of a process that you have to do.
Thank you. And Yvette, there's probably a few questions left in the chat box if you're happy to answer them whilst our next speakers present the presentation, if that's okay. They're just on screen there.
Yeah, thank you.
Thank you so much, Yvette. So we've got our next speakers for the next presentation on critical success factors for implementing EPS in CAMHS, and I'm really pleased to introduce Beanish, who is the Pharmacy Directorate Lead for Essex and Kent at NELD. She has an extensive background of working in hospital pharmacy in the NHS and private sector, and she works closely with system leaders and stakeholders to deliver on workforce planning, service development and transformation within her directorate in the organisation. Beanish is passionate about achieving strategic aims and workforce priorities and improving patient outcomes aligned to national programmes. Beanish is joined by Pav, who is a lead pharmacist for pharmacy informatics and digital medicines at NELD. She has an extensive background working as a clinical pharmacist for the NHS. From embarking on a journey as lead ePMA pharmacist, her role has expanded to delivering a wider digital medicines programme across her organisation. Pav is passionate about achieving positive outcomes for patients through clinical informatics, transformation and innovation. I'm going to hand over to Beanish and Pav, and please have put your questions in the question and answer tab, which is available on screen. Over to you.
Thank you, Amna. Okay, so hi everyone, I'm Pav and I'm joined here by my colleague Beanish, as Amna's just mentioned. We're here to present today our project around electronic prescription service, i.e. EPS at NELD. Next slide, please. So this particular project focused around our Kent CAMHS community services. So just for some of you that may not be aware what CAMHS means, it's child and adolescent mental health services. These services provide care to our patients that may be suffering with ADHD, eating disorders, and/or learning disabilities. The services work across 10 hubs across that Kent patch that you can see on the slide there. The red dots on that map represent the 10 hubs, and you can see that large geographical area that these services are covering. Medication is supplied to our patients via FP10 prescriptions, with the majority of prescribing taking place for repeat prescriptions. Next slide, please. Now, since 2019, the Trust's ePMA system had been used to prescribe FP10 prescriptions electronically. Now, these services, with the sheer caseload volumes that they have a very high prescription volume. We also had quite a key limitation in our previous ePMA system, in that prescriptions still required printing. Now, with those two coupled together, it led to quite significant challenges for our Kent CAMHS services covering that large geographical area, in that those printed prescriptions either needed to be collected, or services were reliant on posting those prescriptions out or using courier services to get the prescriptions out to where they needed to be. What we really needed was EPS. Next slide, please. So for those that may not know, EPS, or Electronic Prescription Service, basically allows prescribers to send prescriptions electronically directly to a patient's community pharmacy of choice. Now, this streamlines both the prescribing and the dispensing process at the community pharmacy end, making the process more efficient and convenient for not just patients, but staff as well. Now, the diagram that I have on the screen here, that's taken from the NHS England website, I just want to draw your attention to that section in the middle there that shows secondary care linking in with EPS. It's really important, I think, to highlight that EPS for secondary care has really only come about in the last 2 to 3 years. It's only really been available in the primary care sector. So next slide, please. So in terms of our journey here at NELFT, we procured a standalone EPS solution via a NEL ICS collaborative approach back in 2022, and there were 5 organisations across our ICS involved. Now, although we procured the solution as a collaborative, each organisation was responsible for its own project delivery. So here at NELFT, we stood up our own project team, and we worked collaboratively with the system supplier, NHS England, and key stakeholder groups from across Kent services, namely the prescribers and the admin staff that deliver those services on a daily basis. And I just want to highlight that it's the first implementation of its kind in CAMHS services to the scale that we've actually done at NELFT. We had quite an ambitious timeline, in that we wanted to go from contract signature at the end of October 2022 to full rollout across the Kent services by the end of March 2023. However, the reality was, and can I have next slide, please? The reality was that we didn't actually complete rollout until the end of November last year. Now, there were some key points that I want to highlight that led to that slightly longer timeline. So first of all, there was actually a delay to the contract signature. There were some complexities around that collaborative approach that we were able to ultimately address and get the contract signed off. So that took place in December 2022. Also, internal governance processes, we needed to tighten those up, especially for this particular project, which were things like the DTAC sign-off. We also had to take into consideration across all key stakeholders involved the NHS England accreditation and request for change process, which is quite different to deploying sort of an ePMA solution, because you do have a key third stakeholder involved that ultimately needs to sign off any application that you're going to go live with. So we had to take that into account. Secondly, we also needed to take into account a second cycle of testing and subsequently the clinical safety case sign-off, because without that, we can't go live. And then also working within the resources that we had available within the immediate project team to deliver this project to success. So all that put together led to the timeline that you can see on the screen there. Next slide, please. So some of the key considerations for implementation for this type of projects, at EPS in particular for us, was making sure that we had the right key project team members, i.e. the immediate team members involved. So that included myself and Beanish as the leads directing the project. And then the Kent pharmacy teams, they were really important and crucial because they were on a daily basis working with our stakeholders at service level, so the prescribers and the admin, and they had that direct contact with them. So they were really key in this particular project, as well as obviously other members of the pharmacy informatics team to help this project get to success. The second thing was ensuring that we had healthcare informatics team members involved, particularly our ICT engineer. The reason for that was that this particular application is a local application and has to be installed on individual user devices. So in order for any user to actually use the application, we needed to make sure the ICT engineer was installing the relevant software and application on individual user devices. EPS also requires certain smart card role access to be assigned, which we didn't have before. So another important aspect for us was making sure we had a dedicated RA agent from our smart card team to make sure in a timely manner, user smart cards had the right access to be able to access the EPS application and subsequently prescribe, etc. Now, in terms of implementation, we did decide to go down the route of a pilot followed by a phased rollout. Now, there was a couple of reasons behind this, namely making sure that we had time to work out if there was going to be any issues that cropped up versus any process changes that needed to take place. So we went for a 4-week pilot site. We selected the site. First of all, we wanted to go to a high prescribing site so we could capture as many different types of prescriptions being prescribed and the volume as well to make sure that we could successfully sign off and roll out. And as well, having services where we had champions in essence wanting to embark on the EPS journey with us. We then rolled out, as I've mentioned, via a phased approach, so each hub going live in one after another in succession. And the key reason why we decided to do that links back to some of what I've already said around the resources that we had available, because past experience showed us that having on-site floor walking support was crucial for successful go live. So each go live, we had on-site floor walking support for the week of go live. Next slide, please. I just want to touch on now some of the key challenges that we as NELFT had within our ICS, because we were the only organisation going from one digital solution to another. So these challenges were unique to us. The first of these was now our prescribers being presented with a lack of pre-configured drug files with dose and frequency, which we did have in our ePMA system. So what we did, we were lucky in that we worked with our supplier and they were listening in terms of the challenges that we were faced with. And what we did was work with them to develop some short codes that we implemented in the application. So, for example, dose and frequency, and an example that I've got on the screen there, 1TAOM, prescribers could use that abbreviation, that short code, that would then expand to take 1 tablet each morning so that the prescriber didn't have to actually type that set of instructions out in full. We then had to think about quantity calculations because a prescriber was now faced with having to do that for each prescription or prescribed item that they were wanting to send via EPS. Now, for our services, this was a challenge because of the complex prescribing regimes and in particular the liquid preparations that are prescribed for our children and adolescent patients. So we came up with quite a simple but effective solution, and that was a quantity calculation crib sheet that the prescribers found extremely useful in their prescribing workflow. The other thing we had to now start thinking about was the fact that we never had to think about the ultimate destination of the prescription because we were handing paper prescriptions to patients, whether they were collecting them or via courier, etc. We now had to think about that end destination. Which nominated pharmacy do we actually need to send the prescription to? So what we decided to do was collate that information from our the parents and carers of the patients, and record that in the patient's EPR record, and that formed part and parcel of the prescribing workflow, that the prescribers had that information to hand at the point that they wanted to send the EPS prescription. We also had to think about this change of process, this change of prescribing that we were looking at. How are we going to communicate that with all our patients? There's thousands of patients that we care for on our caseloads. So what we decided to do was tap into something that was already established, and that was mass texting. And this was already being used as a form of communication with the patients that we care for in Kent. So we tapped into that and sent out the communication that way. And finally, we were faced with having no allergy recording in the system. And this is something that, again, we're working with the supplier on via a user group to develop allergy recording functionality in the system. But for now, we're working with a manual check in our EPR record, and that's why that solution is in red, because we're moving towards a better solution. Next slide, please. So in terms of training and support model, we had to really start thinking about the fact that our Kent services are quite remote to the rest of the organisation, and how we were going to deliver training and then support as well, which includes ongoing support. So coupled with the limited resources, what we decided to do was, yes, we needed to deliver training to both prescribers and admin staff. We decided to go down the route of virtual training via an e-learning module, and it was simply by doing an MS Teams video recording. This has proved to be really, really effective, because number one, our prescribers and admin staff are able to view that e-learning module in terms of getting them ready to use the application in the first place, but they've also got something that they can refer back to at the point that they actually start using the application. Support model, we went down the route of using MS Teams. A support channel has been set up on there. We use the Teams chat function to be able to pop any support questions on there. We also have overview PowerPoint presentations and quick guide videos, so snippets of the main e-learning module that people can refer back to if there's certain things they need to look at. And then we've also developed a frequently asked questions section that people can constantly refer back to. Next slide, please. And I'm going to hand over to Beanish.
Thank you, Pav. So we're going to share some of our key learning points with you. We felt that there was a need for defined baseline prescribing functionality from the suppliers across the system. Digital has come leaps and bounds in the last decade, and we feel that intuitive prescribing should be made available as a bare minimum, such as availabilities of an allergies recording box. Between this and our existing implementation of a digital solution, the key learning point was the accreditation element from NHSE. And although it is between the supplier and the NHSE, it is useful to be aware of what is being accredited and incorporating that in your project timeline, as it can lead to an untimely delay. We wanted to highlight the importance of the clinical safety case. There can be an assumption in the system that the clinical safety case will be signed off for any digital solution. However, any solution can also present some issues as well that require mitigation or resolution. So clinical safety case was integral for us in highlighting and taking forward these issues, and to ensure that steps were in place to ensure a safe implementation of the solution across our services. I want to emphasize that the clinical safety case is an ongoing piece of work. So as further aspects are developed within the application, the clinical safety case does need a refresh. Sometimes the issues within a project can be presented or can come across as project nuances. So a solution really should be as intuitive to your practice as is feasibly possible. So it's important to be open and transparent about issues, as that is the best way to come across other colleagues across the system who may have similar experiences to you. And sometimes this can be a gateway for system change as well, to ensure that the process is more streamlined for others. Next slide, please. So this is a visual. It shows the simplified process since the implementation of the EPS. So it showcases the before process and how the after process has been simplified due to implementation of EPS, simplified due to no need for logging in paper prescriptions and processing them for courier and postage. Next slide, please. So in terms of where we are today, so we carried out our pilot in July 2023 and our rollout was complete in November 2023. So to date, we have 108 users of the system, 55 prescribers and 53 administrators, and we have sent just over 21,000 prescriptions via EPS. Next slide, please. We wanted to talk through some of the benefits of the solution to our service and the system. So we're moving from the left-hand side of the screen to the right. So firstly, there are no paper prescriptions in use. So inevitably, there is much more improved security and governance in prescription management process. There is improved system efficiency. There is no need for postage or courier service. There has been time that's been released into the system for our admin staff in particular due to the changes in prescription management process. And more importantly, and in line with the main drive behind this project, prescriptions are available closer to home for our patients. We have also gained an additional functionality in the form of prescription tracker from NHSE for better oversight on prescriptions as well. Next slide, please. So in addition to, or as part of the benefits realization work, we are carrying out further work to capture savings across the system. So the main things that we are looking at are the cost savings to the system. So there's a total of over 10K savings made due to a lack of paper prescriptions and due to no need of the printers anymore. There is a reduction in the carbon footprint as well. And over 1,100 hours of time savings have been released into the system for our admin staff. Some of our figures will be recalculated in December 2024, which will be 1 year post rollout or post completion of rollout. Next slide, please. We have some case studies to showcase the benefits of the solution for our patients. So this is patient A who lives in Leysden-on-Sea, which is 9.5 miles from our hub. And a return journey for the patient is 19 miles, but because the bus frequency is once every hour, it used to take the patient 3 hours to collect their prescription. So since EPS has been implemented, there has been reduced time taken to collect the prescription for the patient because it's available much more closer to home. This patient was also affected by the cost of living crisis, and affording bus fare was a challenge. So being able to collect prescription closer to home has resulted in some savings for them as well. Next slide, please. So patient B is a 13-year-old patient who lives in a care home and they required frequent adjustment to medication based on symptoms. It was much more easier for them and the prescribers to adjust medication once the EPS was in place. Patient also received it in a timely manner. It also meant less travel for our care home staff, as well as less prescription queries on the prescription whereabouts, as naturally the care home staff had to manage the patient whilst awaiting medication previously prior to implementation. Next slide, please. So although this is one case study, this patient C represents a large number of patients across the system who have been affected by the national ADHD medication shortage. A prescription change was required to dispense an available brand. The EPS allowed for changes to be made much more quicker, with prescriptions being sent directly to community pharmacies in a much more timely manner. This would have been very difficult to manage with paper prescriptions, and especially in getting them to the patients on time to avoid any missed doses due to medication unavailability. Next slide. And yeah, thank you very much.
Thank you both. It's generated a lot of questions in the questions box. There's obviously everyone's quite interested in obviously your EPS journey and the success that you've had with it. So I'll just start with a few of the questions. The first question actually was around when you did go live with the project, how long did you support each site for? And was the support you provided the team remote or face-to-face? Oh.
Sorry, I was just unmuting myself. Apologies. So we provided floor walking support as well in the Go Live week for our service users. So we had a technician who supported our staff in getting onto the system and any help with training. During the very first week when we had the pilot going on, we did have some support from NHSE staff as well. And what was the second part of the question, sorry?
Just bear with me 1 second. And did you provide the support remotely, or was it like face-to-face support that you provided the team when you went live?
Yeah, so in addition to the floor walking support, there was support available for them remotely as well, as Pav had highlighted earlier. So there was an MS Teams support channel for them. There was a chat function where they could drop queries. There were quick guides in there and a lot of frequently asked questions as well that were based on the prescribers and admins and what they had asked us during the training sessions.
Thank you. And there was just a question around the EPS and allergy recording. I think someone wanted to just check. Did you say that the EPS system does not have the ability to record allergies? Is that what
that is correct? That is correct, Amna, and for whoever's asked that question, yeah, you can't record allergies as it stands right now, but I do want to emphasise that the supplier has this on their roadmap, and by the wider user group, we're moving towards having that functionality available. So at the moment, there is a prompt. When I say prompt, there is text in the prescribing workflow that highlights to the prescriber you must check the allergies before you continue to prescribe. So there is a prompt in the system in that sense, but yeah, there's no actual allergy recording.
Great. And then there was another question around, it's just moved off, so a lot of questions coming in. It's saying, is the standalone EPS module integrated with the ePMA that is used at the trust for ePrescribing? And that was from Ashok.
No, so currently this is a standalone solution, and part of the sort of next steps for this project is to look at the integration piece. So our previous ePMA system is now not used across the Kent services. It is now solely the EPS solution. But in terms of linking in with our EPR, we do have only at the moment the copy, and it is a copy and paste function. I'm going to have to say that where we are able to at least copy the prescription information from the EPS solution into the EPR. But what we're looking to do is have an integration element where the prescription information automatically goes into the EPR, but that's another project that we'll be embarking on in the coming months.
No, that's great. It sounds very interesting, and I'm sure we'd welcome you back once you've completed that project. There was a question around actually the situation where occasionally, if you have a patient that's in transit, in terms of their nominated pharmacy, for example, if they're moving house or they're going on holiday, how do you manage any last minute like redirection to another pharmacy? Like what would happen in that case?
So there's actually a few different ways that could be managed. Now, either the prescription can be retrieved, and by that I mean through the EPS workflow, retrieve that prescription from the current nominated pharmacy, re-prescribe it for a new pharmacy if that's what the patient wants. But however, EPS is pretty clever. So in that, if it's sent to a particular nominated pharmacy, as long as that pharmacy pushes that prescription back up to the spine, that prescription is then available if that patient takes a token from their that original nominated community pharmacy and take it to another pharmacy. That pharmacy, the other pharmacy, can then actually dispense that medication for that patient. So it depends on how you want to manage it, because it can actually be managed at the community pharmacy level. And this is actually general practice, because obviously EPS has been out in primary care for a very, very long time. And I've seen it myself through my own experience that just because it's gone to one nominated pharmacy doesn't mean to say that if they don't have that particular medication, you can't then get it from somewhere else. So there is a way of managing it. And I'm happy to go into more detail if anybody wants to know about that, if they reach out to me.
That's great. Thanks, Pav. And just some clarity, actually, there's been a few times it's been asked about actually the EPS system that you're using within the organisation itself.
So I believe at the moment there is only one available, and it's Clio EPS that we do use. So although we have been faced with, I've said challenges, but we've been able to work out new workflows, and to be honest, the feedback we are getting from our users is absolutely amazing since we've implemented EPS. The way it's changed the way the service works from a prescription perspective, it's really made some significant savings, and patients are getting their medication in a timely manner, putting aside the ADH medication shortages.
Yeah, that's great. And just in regards to record keeping, so there's a question from Geordie about, do you still keep a record of the drug and the dose the patient is on in your current EPR system? So not the EPS system, in your actual current EPR system? Or
so the electronic patient record, yes, we do. We do use within the application as it stands right now, there is a copy prescription function. So once the prescriber gets to the end of that prescribing workflow, having sent the prescription via EPS, you can copy the prescription information, which will pick up every single item that's been prescribed, the dose, the frequency, and the quantity supplied, as well as the script ID. So EPS introduces this script ID sort of concept, and that can be then entered into our EPR, and that's how we're keeping a record of what's actually being prescribed in the Clio EPS solution.
No, that's great, and thanks for clarifying that. And there was another situation or question around, do you sometimes ever have to use any old FP10 prescriptions still? Have you ever had instances where you've had to do that? Is that still part of the workflow?
It is basically our BCP for Kent. In the event that it's possible that a drug file is not available in the EPS solution. So in those instances, paper prescription is our backup, that you would have to revert to that. And what we usually do is then raise relevant queries with the supplier to get that resolved. So yes, there are still cases where paper prescriptions are required for certain instances, as I've just described.
Thank you, Pab. And then just a bit about the actual system itself. Does the system have any warnings or pop-ups for guiding prescribers on restricted use of medications, for example, quinolones in pregnancy or other restricted medicines, or aminoglycosides? Does it have anything within that EPS system that pops up for the prescriber? Dina?
Ines, do you want me to take this one as well?
Yeah, that's fine.
So basically, as a drug is selected for prescribing, there is some warning information in the system, whether it be due to interactions with what's already prescribed in that instance of prescribing for the patient. So it's in that session. So interactions, contraindications, there is some element of that clinical decision support element in there that prescribers do have reference to. So yes.
And there was a question around Clio and adding drugs. Is there a lead time for Clio to add drugs files to the system? So that must be a request.
Yeah, so there is an element. EPS, the applications are based on the national sort of SNOMED coded database of drug files. But if there is a drug file that you come across, and we have come across the odd one here and there, the lead time can vary depending on what the actual issue is. If it is simply that this prescription is missed, this drug file is missing, then that turnaround can be relatively quick. However, if there's nuances in the system in terms of the drug file's there, but it's not quite doing what you want it to do, then that can take a little bit longer, because we end up having to investigate, working with the supplier, sometimes NHS England, to understand, well, why is that drug file not there? So the honest answer here is the timeline can vary, and that's why I link back to, we sometimes do have to use a paper prescription.
No, that makes sense. Thanks for that clarity. And there was just in regard again to the actual drug files, there's a question around, are they configured to the virtual medicinal product level in terms of the mapping?
Yes, they are, and you can actually go down to the MPP, so pack level, depending on what it is quantity-wise that you're wanting to prescribe. So the way we've trained our prescribers is you can either select the VMP, so the virtual medicinal product, or you can actually go down to pack level. We found the pack level element quite important, especially where liquid calculations were involved, because what we wanted to avoid was sending a prescription over to a community pharmacy where we're then having to get them to break original packs of liquids. So the pack element has proved to be really, really beneficial for this prescribing workflow.
Thanks, Pab. And then there was a question from Robert about actually the red drugs, and it was, do we need to deal with red drugs differently now because of EPS?
I'm going to probably have to come back to that question, Amna, in terms of red drugs, and address that with a bit more detail, if that's okay. Apologies, I'm not able to answer it now.
No, that's absolutely fine. We can send the questions. Sarah will send it to you separately, and the questions that we weren't able to answer in today's webinar will get put onto the futures page, so you'll be able to answer that later. But in terms of, there's a few left, but you can answer them offline, Pav and Beanish, if that's okay.
No problem.
And I'd just like to take this opportunity to thank both of our presenters today. Well, both presentations, we had Yvette and then Pav and Beanish, who were able to share their insights and their journeys in the challenges and strategies for ePrescribing mental health. And we just heard now about having EPS, implementing EPS in the community. And the next masterclass is on Wednesday, the 16th of October. The QR code to register is on screen now. And the session will be on the ePres program team about learning from the last 2022 version rollout. And they'll be showcasing the new tool and inviting you to get involved. As I said at the start of the presentation, if you've got any ideas for future topics or you'd like to volunteer to present at a future session, please do email Sarah Black from the Health Innovation Network. And the recording of this presentation will be available after the session today. Just to remind you, you will get a certificate for attending today's masterclass, and any questions that have not been answered in today's sessions will be available once we've received the answer from our presenters on the NHS Future platform for you to have a look at after the session. Once again, thank you today for joining the masterclass. It was great to see so many of you here, and I hope to see you all in October. Have a great rest of the day. Bye.